Good evening, everybody. Welcome to this case discussion episode, a special edition on Anesthesiology Webinar Campus. I know it's been a while since we met on the platform of Webinar Campus. This is basically a postgraduate oriented academic program. I can see many of my friends, colleagues, seniors, teachers, and students known to me in the attendees list. Thank you very much for joining. Today we have planned a case discussion, mitral stenosis patient for non-cardiac surgery. Today's format will be like this. Initially, there will be a case presentation by Dr. Shinu Fathima, who is a final year DNB postgraduate student from Trivandrum. And the examiner will be Dr. Minati Choudhury, who is a professor cardiothoracic and vascular anesthesia and critical care from the prestigious All India Institute of Medical Science, New Delhi. The initial case presentation will last for 25 minutes, as happens in the postgraduate examination. And during that time, the candidate will be interacting with the examiner. Then we'll see how the case presentation went, a kind of debriefing for a short while, maybe 5 minutes. Then we'll have a lecture on the topic mitral stenosis for non-cardiac surgery by our esteemed faculty, Dr. Minati. And from the audience, we would like to have a continuous participation. There will be a lot of audience questions. We have already circulated a few of the questions in our Anesthesiology Webinar Campus Telegram list, and there was a good enough response. But we find that the people hitting the right answer is not coming up to an unanimous thing. See, some of the answers, right answers are hit by only 40%. So we would like to enhance this, and we'll have some more questions during the case discussion as well. And for the audience, you can put in your questions in the chat or Q&A box. We'll address all your questions and queries towards the end of the sessions. So until then, from the participant side, you also will be involved throughout in our case discussion. So this is the format. Now it's over to Dr. Minati to start the proceedings, and Dr. Shinu will be presenting the case afterwards. Dr. Minati, please. One second, there is some internet connectivity issue. We'll sort it out now. Dr. Minati, you can start the case presentation discussion part.
Dr. Shinu?
Yes, ma'am. Good evening, ma'am.
Good evening. Please present your case.
Okay, ma'am. Ma'am, Rajesh, 32-year-old male who is coming from Trivandrum. He is an electrician by occupation. His presenting complaint, he complains of swelling over the right inguinal-scrotal region since 2 years and pain over the inguinal region since 3 months. And the history of presenting illness, patient complained of swelling over the right inguinal-scrotal region since 2 years. The swelling gradually increased in size over the past 2 years, and it reduces on lying down position and becomes prominent on coughing and straining. The swelling is associated with intermittent dull aching pain, aggravated on straining and relieved on leaning forward. And there is no radiation of pain, no history of any vomiting, yellowish discoloration of eyes, constipation, abdominal distension, no history of fever, difficulty in micturition, no history of any swelling in the contralateral side. Then coming to the past history, the patient is a known case of valvular heart disease diagnosed at the age of 22 years. The patient had history of pain, fever with joint swelling in the ankle and knee joint at the age of 12 years, which lasted for 2 weeks and subsided with medical management. Patient developed an exertional dyspnea at the age of 22 years. The breathlessness was during severe exertion, and he took medical management for the same. And now he again developed breathlessness for the past 1 year. Initially, the breathlessness was only with severe exertion. Now it is even with ordinary activity, NIHA class 2. No breathlessness during rest. Patient is having no history of any chest pain, palpitation, no history of any paroxysmal nocturnal dyspnea, orthopnea, no history of syncope, recurrent respiratory tract infection or hemoptysis. There is also no history of any abdominal distension, swelling of the leg, oliguria, nocturia. There is no history of hoarseness of voice or dysphagia, no history of bluish discoloration of finger toes, and no history of weakness of limb or deviation of angle of mouth. There is no history of diabetes, hypertension, asthma, seizure, jaundice, tuberculosis, or no history of any drug allergy, and no history of any recent respiratory tract infection. And then coming to the treatment history, patient is on.
From the history, can you stop here?
Yes,
From the history only, and what you can gather about the case in brief.
Ma'am, the 32-year-old patient male, he's a known case of valvular heart disease, most probably rheumatic in origin, since he have a history of pain, fever, of joint swelling at the age of 12 years. And now the patient is having an exertional dyspnea in ordinary activity, corresponds to NYHA classification 2. There is no history of any paroxysmal nocturnal dyspnea or orthopnea, and there is no history suggestive of any congestive cardiac failure or atrial fibrillation or infective endocarditis. The patient now presented with the right inguinal scrotal swelling, and
So what? How do you classify? What is NYHA classification? How you will classify the dyspnea or palpitation according to NYHA grade?
Ma'am, the NYHA classification, the main 4 components is the dyspnea, palpitation, fatigue, and syncope. In NYHA class 1 patient, the patient with heart disease where there is no limitation of physical activity, that is ordinary physical activity, there is no dyspnea, palpitation, angina, or fatigue. In NYHA class 2, the patient with a heart disease have a slight limitation of physical activity. That is, a patient feel uncomfortable on doing the ordinary physical activity. And in NYHA class 3, the patient is having a moderate limitation of physical activity. The patient is having dyspnea on exertion on the less normal physical activity. There will be dyspnea, palpitation, fatigue, and angina. And in NYHA, that is class 4, the patient is having all these symptoms at rest also.
Okay, what do you mean by orthopnea and PND?
Ma'am, orthopnea, the patient find breathlessness on lying down position, and it is relieved during the proper position or sitting position. And the paroxysmal nocturnal dyspnea, patient find difficulty in sleeping. In between the sleep, he finds uncomfortable and awake from the sleep. After 2 to 6 hours after deep sleep, and it will relieved after 10 to 30 minutes of sitting or awake.
So why orthopnea happens, and why do you think that anesthesiologist?
Hello, ma'am.
Why or what is heart disease, and what is the significance of orthopnea and PND for the anesthesiologist?
Ma'am, the PND and orthopnea corresponds to the NYHA classification 4 or 3. So when there is the orthopnea is mainly due to the increase in the transvalvular. In MS, there will be increase in the transvalvular pressure, which will increase in the left atrial pressure. Because of the increased left atrial pressure, there can be pulmonary congestion, and because of the pulmonary congestion, there can be the increase in the interstitial edema and can cause congestive cardiac failure. And also in patient with there can be in paroxysmal nocturnal dyspnea, the patient also feel during the night time there will be decreased sympathetic activity, which will causes decrease in the LV function, which can which also affect the
Okay. Very good. And now we can proceed for the treatment history.
Yes, ma'am. Treatment history: patient is on beta blocker, tab metoprolol 25 mg twice daily, and the patient is also taking tab penicillin, phenoxymethyl penicillin 250 mg twice daily, and there is no history suggestive of any ICU admission. And the personal history: the patient is non-smoker, non-alcoholic, bowel and bladder habit is normal, his appetite and sleep is normal. And family history: the patient is having no history of similar illness in the family, no history of any diabetes, hypertension, CAD, tuberculosis, bronchial asthma in the family. Okay, ma'am. This is about the history.
Carry on.
Okay. Ma'am, on physical examination, the patient is conscious.
Which group of drug this metoprolol is?
Ma'am?
Which group of drug this metoprolol is?
Beta blocker, ma'am.
Which group?
Metoprolol is a beta-1 selective beta blocker, ma'am.
So it is a cardioselective beta blocker. What are its side effects?
The beta blocker, it can cause, it will decrease the heart rate, and also in MS patient, the tachycardia is very detrimental because of the decreased diastolic time. So for that, we are giving metoprolol to decrease the tachycardia and to promote the diastolic time.
Now, what are the side effects of metoprolol, and what is the advantage of metoprolol over propranolol?
Metoprolol is having a beta-1 action, so it is more cardioselective, and it's having a direct action.
Can you give it to patient in bronchial asthma as well?
It is contraindicated in bronchial asthma, ma'am. So it is not given in patient with bronchial asthma, beta blockers.
You have to be careful about metoprolol. Propranolol is a contraindication. For metoprolol, you have to be a bit careful.
Okay.
So, in non-rheumatic heart disease patient, what else drug can be given?
In non-rheumatic patient, ma'am, a secondary prophylaxis for rheumatic fever can be given.
The patient is already on penicillin. Apart from that,
the patient, we can give diuretic if the patient is having any congestive cardiac failure, any history of any congestive cardiac failure. The patient can be also in a rate control for digoxin. Digoxin can be also given, and diuretics, digoxin, beta blockers. Then
it's okay. Now we carry on for the physical examination.
Okay, ma'am. So, ma'am, patient is conscious oriented in time, place, and person. He's an average build and nourished. His height is 160 centimeter, weight is 60 kg. The BMI is 23.4 kilogram per centimeter square. There is no pallor, icterus, cyanosis, clubbing, lymphadenopathy, and pedal edema. The vitals, the pulse rate is 58 beats per minute. It is regular, normal in volume and character, no vessel thickening, no femoral or radiorenal delay. All peripheral pulses fell bilaterally equal. JVP is not elevated. Blood pressure is 100/60 millimeter mercury in right upper limb sitting position. The respiratory rate is 16 per minute, regular abdominothoracic. The temperature is he's febrile. The spine, thyroid, etc. is normal. Then airway examination. No facial asymmetry. The external nasal framework appears to be normal. Mouth opening is more than 3 fingers. The thyromental distance is about 3 fingers. The mallampathy classification is grade 2. And there is no loose tooth, no artificial dentures. Neck movements is normal. Teeth fat.
In your general physical examination, what are more pertinent to this cardiovascular problem? Because it is a diagnosed case, you said, diagnosed case of some valvular heart disease. So what are the things in general examination you want to see specifically?
So from general examination, ma'am, if the patient is having a history of MS, there will be the mitral phases will be there. So there can be malar rash over the face.
That is not important, much important for us. What is important for us being anesthesiologist?
Ma'am, then we can have the heart rate, the JVP. If the patient is in congestive cardiac failure, the JVP will be elevated.
No, one is JVP.
Then ma'am, we can look for the pulse. Then pulse in a normal, the pulse that will be regular, normal in volume character. But if the patient is in AF, there will be irregular pulse. So from the pulse, we can identify the underlying, if there is an underlying AF or not, or any other valvular disease. Then
you want to see for the failure sign of right ventricular failure as well at the same time?
Yes, ma'am. Right ventricular failure sign. If there is any bilateral pitting, pedal edema is there. Then, ma'am, clubbing. Then, from the pala, we can look for any anemia because of
you want to see any rheumatic activity, recent rheumatic activity,
rheumatic.
Active carditis, ongoing active carditis. You want to see?
Yes,
you want
yes, ma'am.
to. So how you are going to examine for that, or what else you have to ask for? There is one thing, if there is a change in the original murmur characteristics or appearance of the new murmur. These are the two important things in which you can know some rheumatic activity phase is going on.
Okay, ma'am.
So now your airway is normal. You have Mallampati grade 3, you said, right?
2, ma'am. 2.
Mallampati grade 2. And then come to the examination proper.
Okay, ma'am.
All the systemic examination.
Okay, ma'am. Coming to systemic examination, on inspection, cardiovascular system examination. On inspection, the shape of the precordium is normal. The apical limbus is visible in the left fifth intercostal space. No other visible pulsations, scars, or dilated vein. On palpation, there is no local rise in temperature or redness. The apex beat is palpable in the left fifth intercostal space, 1 centimeter medial to the midclavicular line. It is tapping in character. A diastolic thrill palpable in the apical region, best felt in the left lateral position in full expiration. There is no parasternal heave or no epigastric or suprasternal pulsation. On percussion, the left border of the heart corresponds to the apex beat and the right border of the heart corresponds to the right sternal border. And on auscultation, mitral area, there is loud heart sound, and there is an opening snap after the second heart sound, and a low pitched rough rumbling murmur, mid diastolic murmur, grade 4/6 with pre-systolic extenuation is present, best heard in the left lateral.
Opening snaps happens.
Ma'am, the opening
snap happens.
So, ma'am, during the opening snap happens just after the second heart sound, when when there is an increase in the transvalvular pressure, the left atrial pressure increases. When the left atrial pressure increases, when the mitral valve is open during the diastole, there will be an opening, high pitched voice, high pitched sound is heard. That is the opening snap because of the increased LA pressure and increased transvalvular gradient.
So you have a opening snap, you have a parasternal heave, you have a mid-diastolic rough rumbling murmur, right? So till now, these are your findings. What about your respiratory system examination? Is it normal? It is abnormal?
Yes, respiratory system is normal. The upper respiratory system is normal. Lower respiratory inspection, the shape of the chest is normal. Trachea is central. The chest is bilateral. Movement of chest bilateral equal. And on palpation also, there is no local rise in temperature. The apex beat is palpable in the left fifth intercostal space medial to midclavicular line. The chest movement is equal. The vocal formatus is equal on all lung field. And in percussion, there is normal resonant sound heard over all lung area. And on auscultation, there is normal vesicular breath sounds heard on both.
Patient is in pulmonary edema. What finding you will get in the chest?
In pulmonary edema, ma'am, there will be bilateral coarse crepitation will be there in the basal area, and also in the basal area. And
suppose there is pleural effusion at the same time.
Okay, pleural effusion, the air entry will be decreased on the side, and also the patient on the palpation and all, the vocal tremulous will be reduced on the both sides, and also the vocal resonance will be reduced during pleural effusion.
Okay, what other system you are going to examine?
Next one, the gastrointestinal system. The system, the upper GIT appears to be normal. The abdomen inspection shape is normal. Abdomen not distended. The umbilicus is central, not inverted. No dilated veins, scars, sinuses, or visible pulsation. Then palpation, no local rise in temperature. Abdomen is soft, though no guarding, no rigidity, no hepatosplenomegaly. On percussion.
So hepatosplenomegaly, you are particularly going to look for to see the sign of ventricular failure.
Ventricular failure. Okay, ma'am. Yes, ma'am.
And what about CNS? What are the specific thing you want to see?
Ma'am,
Or
CNS.
you don't want to examine the central nervous system?
No, ma'am. For CNS, we have to look for, because if the patient have thromboembolic episode, so they have focal neurological deficit will be there. So we have to examine the CNS system. So in CNS system, I've examined the higher mental functions appears to be normal. It's conscious oriented, normal behavior, normal intelligence, memory, speech, etc. normal. The motor system, super sensory system, cerebellar function, autonomic
So
system,
no
all
abnormality detected in the central nervous system as
central
well.
nervous system.
Not in the
Yes, ma'am.
CNS, not in the PNS. Right?
Yes, ma'am. Yes,
So
ma'am.
how you are going to proceed? This patient is what is your provisional diagnosis now?
Okay, ma'am. The summary is a 32-year-old male, non-case of valvular heart disease with exertional dyspnea, NYHA class 2, with no history of pain, orthopnea, or no history of features suggestive of congestive cardiac failure or atrial fibrillation, infective endocarditis. On examination, the patient had a tapping apex, diastolic murmur and trill, loud S1, with presystolic exsinuation and opening snap, now presented with feature of indirect inguinal hernia.
So this is a rheumatic heart disease, right?
Yes, ma'am.
So what are Jones criteria for rheumatic heart disease?
Ma'am, the Jones the Dr. Jones criteria mainly have major criteria as well as minor criteria. In the major criteria, there are 5 points. There is carditis, then fleeting arthritis, then patient having Sydenham's chorea, erythema marginatum, and then subcutaneous nodules. And in minor criteria, the patient is having fever, arthralgia, and on examination, laboratory examination, there will be increased total count, increased ESR, CRP, and also in ECG, the PR interval will be prolonged.
So how many major and how many minor criteria one has to satisfy?
Ma'am, 2 major or 1 major plus 3 minor criteria should be there to consider it as a rheumatic heart disease.
Okay. And how this patient is posted for inguinal hernia repair?
Ma'am, proceed for
Right?
inguinal hernia. Yes, ma'am.
So how you are going to proceed? What are the investigation you want to go for? 1, 2, 3, 4, 5, and how you are going to manage your anesthesia?
Okay, ma'am. So, ma'am, investigation part, I am going to look for the complete blood count, mainly hemoglobin. The baseline hemoglobin is recorded. If there is because to rule out any anemia, because anemia can cause this tachycardia and can decrease the filling time. So, baseline hemoglobin is look for. And I also look for total count, differential count, and ESR for if there is any underlying infection is there. Then a urine routine examination is also done to rule out any other urinary tract infection. Then I'll look for serum electrolytes. So if the patient is on digoxin or patient on diuretics, have a decreased potassium level.
Is not on digoxin.
No,
this patient
no,
is not on digoxin. You
no,
want
ma'am.
Electrolyte in patient?
Not only just the baseline electrolyte value, I'll check for.
One baseline value you want to take.
Yes, ma'am. Then baseline renal function also I'll check, urea creatinine, and then I'll do a chest X-ray and ECG.
What are the chest X-ray findings in the case of mitral stenosis?
Chest X-ray, when because of the increased left atrial pressure in chest X-ray, there will be straightening of the left heart border. There will be double cardiac shadow sign because of the increased LA pressure, and also there will be elevation of the left mainstem bronchi. And then because of the increased pulmonary venous pressure, there can be inverse mustache sign will be there because there is increased vascularity in the upper region of the lung. It will be known as a mustache sign or antler sign. And also there can be, if there is an underlying pulmonary edema, there can be curly A, curly B line can be there. And also in pulmonary, if there is a pulmonary artery hypertension is there, then there can be the increase in the pulmonary corners, and also there will be pruning of the peripheral pulmonary arterioles will be there. This is the chest X-ray finding.
And what you want to see specifically look in ECG? What is more important in ECG?
No, ma'am, we have to rule out if there is any atrial fibrillation from the ECG. Then we can also look for P mitral if there is any bifid P wave in lead 2 and biphasic P wave in lead V1, and also we can look for if the for any other ischemia or any. We can also look for if the patient is in right ventricle failure, the R/S value will be more than 1 in lead V1.
Among everything, what is most important in ECG?
Ma'am, ECG, the rate, we have to look for whether patient is in sinus rhythm or if he is in a atrial fibrillation.
Because that will modify some of your management plan. So
Yes,
that
ma'am.
is why it is important. So what specific investigation you want to go for?
Yes, ma'am. We'll go for an echocardiography. We'll do an echocardiography.
Why you want to go for echocardiography?
Patient is a known case of a mitral, known case of valvular heart disease. So, if the patient suggestive of a mitral stenosis.
Patient had undergone echocardiography a month before. Still, then you want to go for it? If you want to go for it, when should you go for it, and if not, when?
So, ma'am, if there is no deterioration of the clinical symptoms, then it is not needed. But if there is a deterioration in the clinical symptoms after that, then we have to do an echocardiography. Repeat echocardiography.
So, what are the things you are going to look for in that?
Ma'am, in echocardiography, we I'll look for the mitral valve area. Then I'll look for the transvalvular pressure gradient. Then, if the patient is having any PAH, that is a pulmonary artery pressure, then the mitral valvular apparatus.
Very good.
Okay.
And what else? So you have done your echo, you know your patient is having suppose grade 2 mitral stenosis. So how are you going to proceed for anesthesia?
So if the patient, ma'am,
you want to go for a angiography for this case, coronary angiography?
No, ma'am, because the echo finding, if it is satisfactory, there's no need for a coronary angiography.
Suppose the echo finding is satisfactory also, and patient is 50-year-old. You want to go for angiography in that case?
No, ma'am.
You don't want to go for
angiography, ma'am, because if in the case of any only in if there is any left ventricle failure or any patient is having any severe in case of severe MS, then we can do angiography. But in routine cases, there is no need for
that case. Otherwise, if he is a male more than 40 years and female more than 50 years, you have to rule out CAD in that case as a routine.
Ma'am. Okay,
so how are you going to proceed for anesthesia?
Sir, ma'am, the plan of anesthesia is general anesthesia with controlled ventilation and with an inguinal feed block for post-op analgesia. So for the patient, I'll do a pre-anesthetic checkup for the patient. So a detailed history and examination part, I'll obtain a detailed history and examination, and after that, I'll go for the investigation. Then
now everything is done. How are you going to proceed for anesthesia?
Okay.
What is your pre-op advice? How are you going to manage intra-op?
Okay. The preoperatively, ma'am, on the day before surgery, the patient, I'll give the I'll get an informed consent from the patient. Then I'll discuss the patient regarding the surgery. Then I'll ask the patient to continue the drugs, that continue the beta blockers and continue the penicillin. And also I'll give a anti-aspiration prophylaxis on the day before surgery and on surgery. After that, on the morning of surgery, our patient is shifted to the operation room. In the preoperative room, the patient, under local anesthesia, I'll put a IV line, 18 to 16 gauge IV line I'll put under local anesthesia, and I'll give a anxiolytic 1 mg midazolam. And after that, under proper monitoring, and also I'll ensure that there is adequate oxygenation. And then the patient is
Why not oral pre-medication?
Oral, madam, on the day oral pre-medication, if the patient is too much, patient will be on the not will be under monitor. So if you're giving a oral anxiolytic, if there is sedation, then it can worsen the can cause hypoxia, hypercapnia, can worsen the pulmonary arterial hypertension. So under proper monitoring, only I plan to give a anxiolytic.
Okay.
Excuse me, ma'am. We'll wind up the case discussion in another 3 to 5 minutes.
Okay.
Okay. Then, ma'am, after the proper monitors, all the I'll check the anesthesia machine and all the emergency drugs and all the drugs for general anesthesia will be kept ready. All the emergency aware cart will be kept ready. Then the patient is shifted to the OT, and the patient all the pre-injection monitors will be attached to the patient. Then I'll pre-oxygenate the patient, and the fluid will be attached to the patient, and we'll pre-oxygenate the patient for 3 minutes with 100% O2. Then after that, I'll give a injection fentanyl 2 to 3 microgram per kilogram. Then under mask ventilation, then I'll induce the patient with the injection etomidate 0.3 to 0.5 mg per kg with the etomidate, and after the mask ventilation adequate, I'll give a vecuronium injection, IV vecuronium 0.1 mg per kg vecuronium is given. After that, gentle direct laryngoscopy and endotracheal intubation is done. After that, it is connected to the ventilator, and a maintenance of anesthesia is with the air, oxygen, and sevoflurane.
You will give nitrous oxide?
Hello, ma'am.
Nitrous oxide?
No, ma'am. I go for air, oxygen, and sevoflurane. Nitrous oxide can, in case of, it can precipitate the pulmonary artery hypertension. So nitrous oxide is avoided in the case. Hello, ma'am.
Listening. So what about your analgesia?
So, ma'am, after the surgery is over, I'm going for a the post surgery. I'm going for a inguinal field block by blocking the ilioinguinal and iliohypogastric nerve before extubation, and after giving
you want to read a defibrillator before for this case?
Yes, ma'am. During all defibrillators should be kept ready as a before starting the surgery.
Can you go for epidural anesthesia in this case?
Ma'am, epidural anesthesia can be given, but there can be the patient can go for hypotension, so it is detrimental to the patient because of the can decrease when there is a decrease in the systemic vascular resistance. To maintain systemic vascular resistance, so I'm planning for a post-op inguinal field block.
Okay. What the post-op analgesia?
Post-op analgesia, I'm giving a inguinal field block post-operatively, and also I can give an IV NSAIDs like paracetamol post-operatively, 15 mg per kg paracetamol, 6th early to 8th early. Then other in this case.
And what is the tentative duration of this surgery, this kind of surgery?
Ma'am, duration is 1.5 hours, ma'am.
Suppose your patient landed up in pulmonary edema in between, what are you going to do?
So, ma'am, intraoperatively, if there is a pulmonary edema, we have to stop if there is, we are using nitrous oxide, we have to cut the nitrous oxide, and we have to maintain 100% oxygen. After that, we have to maintain a proper position, and we can give, if a patient is on a positive pressure ventilation, we can increase the PEEP of the patient, and also we can give a IV, diuretics can be also given to relieve the symptoms. And if the patient is hemodynamically unstable, we can start with any drugs like dobutamine, and also morphine can be also given. IV morphine can be also given, 0.1 mg per kg.
What dobutamine? Why vitamin?
Ma'am, it has a vasodilatory effect. So to relieve the, that's why we're giving vitamin. And also an inotropic effect is there.
Suppose a patient blood pressure is not fluctuating, you want to give vitamin still?
No, ma'am. If there is only any hemodynamic instability, only we can start. Otherwise, no need for any supports, ma'am.
So you have to give 100% oxygen, morphine, and diuretic for the intra control.
Okay, ma'am.
Yes, ma'am. Then only we can go for any inotrope. And if there is features of pulmonary hypertension, then you can go for a inodilator like the vitamin or milrinone.
Milrinone.
Yes.
Okay.
You want to go give NTG, nitroglycerin?
Ma'am, we can give, but there can be reflex tachycardia can occur. So
if sudden decrease in SBR again, it will decrease more. PO mitral stenosis, it is again harmful rather than
harmful.
Any benefit.
Anyway.
Okay, ma'am, it's time up, ma'am. We've actually taken an extra 5 minutes. Shall we wind up the case discussion, ma'am? We'll go for the debriefing. Okay.
Sure.
Okay, fine. I'll start with the presenter.
Okay, sir.
Dr. Shinu, how did the case presentation go? Did you experience any problems in between?
No, ma'am. No, sir. It was okay. The audio was a little bit breaking in between.
Okay. But for that?
Other than that, it was a very good interaction with ma'am. So thank you, ma'am, for this interactive session. And also thank you, sir, for conducting.
You presented so nicely. Thank you so much.
Thank you, ma'am.
Dr. Minati, your opinion, like which all good points in favor, points to improve, like that?
Points to improve. Suppose if it is a short case, it should be a brief presentation.
Okay.
Rather than going into so much of detail. If it is a long case, then it can go on. And no, she has prepared very well. So nothing to improve in that preparation, I can say.
Okay.
Nothing much to improve in that preparation.
I think I should also appreciate many of the participants who were actively putting their input in the chat. So they were very busy texting it. So speaking out is easy, but texting is slightly difficult. But I know there are many people who are actively giving input when the discussion was going on. I really appreciate that. Maybe we'll take a point or two during our Q&A session a little later, because there are a good number of options or suggestions given along with the along the chat, and some of them are Dr. Shinu's classmates. I know some of her teachers are also there in the attendees panel. So we'll come to those questions and points a little later. Okay, ma'am, shall we proceed with the next phase?
Okay.
Okay, Dr. Shinu, please continue with us. We'll take your opinion during the Q&A session again, because many of your friends have given many suggestions regarding the plan of anesthesia and all. You can read through the chat along with that. Now we'll proceed to the part 2 of today's session, which is a lecture by Dr. Minati on the topic mitral stenosis patient for non-cardiac surgery. Actually, we were discussing how to conduct this program. Actually, to describe everything, it will take more than 2 to 3 hours. So what we decided was we'll have a session of case discussion, like what happens during exams. Then we'll briefly go through what the examiner expects when the questions or scenarios are put. Okay, now we'll listen to Dr. Minati.
Screen is visible?
Yeah, visible, yeah.
So thank you, Dr. Saneesh, for such a nice introduction and making me a part of your team. So basically, in mitral stenosis patient, few of the non-cardiac surgical procedures has been done, and some are elective, some are emergency, and there are minor or major cardiac procedure. And again, mitral stenosis in a pregnant patient, they are the specific spectrum of patient in which anesthesia management is there. So while managing a case of mitral stenosis, particularly we anesthesiologists should not forget the basic anatomy of the mitral valve apparatus. If you can see, it has a mitral annulus, leaflet, there are chordae tendineae, there are papillary muscle, and there is adjacent ventricle. And the normal mitral valve area is 4 to 6 centimeters square. Why this thing is important? Because the rheumatic process or most of the mitral stenotic lesion, they involve many part of the valve apparatus. So if one part is damaged, the other part is also dysfunctional. So that is why it is important to know the entire part of the valve. And the annulus, as you can see, annulus is mostly dynamic with an area change of 30 to 40% during the entire cardiac cycle. And the minimum area happens during mid-systole and the maximum area happens during mid-diastole. So what is mitral stenosis? We know, you can see the normal mitral valve, and there is narrowing, much narrowing of the mitral valve. And this, if there is a narrowing, whatever blood can go from LA to LV, that cannot go. So there is decrease in the cardiac output. Again, the causes of mitral stenosis are important being anesthesiologist, because different causes, they manifest in different way, and some causes like carcinoid disease, they have some systemic manifestation. And during intra period also, if there is mitral stenosis due to carcinoid disease or SLE or rheumatoid arthritis, you have to be really careful, because some other changes and systemic involvement is there. You have to tackle those things along with management of the mild or moderate mitral stenosis during a non-cardiac surgical patient. And the most common lesion is rheumatic heart disease in our country. There is also congenital cause, and at times left atrial tumor, especially left atrial myxoma, they impinge on the mitral valve and they look like behave like mitral stenosis. You can see this case of triatum. This the left atrium is divided by another structure. Their membrane-like structure is dividing into two parts. So whatever when the LA is in the systole, it cannot push the entire blood to the LV. So part of the blood is going. So it is also behaving like a case of mitral stenosis. So one has to know this thing also. So this is another case. You can see there is a thrombus-like thing. This is a case of LA myxoma. Mitral valves practically looks thin and normal, but however, this is impinging on the mitral valve, giving rise to stenotic-like feature. So this is a typical rheumatic mitral stenosis. You can see there is a thrombus on the leaflet of the mitral valve. There is narrowing of the valve. The leaflet are looking thickened, and there is lot of smoke inside the left side. That is due to churning or turbulence of the blood flow on the left atrial side. This is important to know because this can give rise to thrombus. So coming to the pathological specimen, as I said, it is involved the entire part of the wall. You can see the leaflet is thickened and there is calcification, there is commissural fusion, and there is a chordae tendineae, there is fusion, there is damage of papillary muscle. So the wall is look like a fish mouth. So hardly anything can go. So what are the pathological consequences? Because there is narrowing, there is left atrial emptying is a delay. So there is back pressure, increase in LA pressure. And this increase in LA pressure, they give rise to gradually enlargement of the LA. There is derangement of the myofibril of the left atrium. And this subsequently give rise to derangement of the back pressure. Again, that goes to the right side of the heart. The entire myocardium architecture is deranged, and that gives rise to arterial fibrillation. So this back pressure again on the pulmonary vessel gives rise to increase in the pulmonary venous pressure, and if it is more, this gives rise to perivascular edema and luminal narrowing. You can see the curly lines. And a lot of pulmonary venous pressure again increase. There is increase in the pulmonary arterial pressure. Why it is important? Because this pulmonary arterial pressure, if it is increased, will change your anesthesia management. And this subsequently decrease down to the cardiac output on the left side as well as the right side, because there is back pressure on the right side of the heart as well. So there is both the sides, the cardiac output is again decreased. And in the subsequent course, again, there is tricuspid valve involvement, tricuspid valve regurgitation. Then the things will be difficult to manage in the non-cardiac theater at times. So what about the ventricular function in mitral stenosis? And in 1/3 of the cases, there is a decrease in LV systolic function. This is basically less of the blood is going to the LV. Most of the blood is remaining inside the right side of left atrium. And there is, due to certain myocarditis, especially in case of the rheumatic heart disease, there is some degree of contractile dysfunction. And next is, there is reflex vasoconstriction. And this reflex vasoconstriction gives rise to decreased cardiac output and further decrease in the ejection fraction. And rheumatic heart disease also involve the posterior basal segment of the heart. So give rise to derangement of the posterior basal segment, hypokinesia. So whatever blood can come, it won't come. So that part of cardiac output is again get inhibited. So there is decrease in cardiac output. Again, because there is inadequate wall thickness, the upload is increased, so that also decreased down to further the ejection fraction due to increase in the wall stress. So whatever the diastolic function, there is chamber compliance is abnormal or chamber compliance is decreased. This is again because of intrinsic myocardial dysfunction and myocardial fiber damage by the rheumatic process. And similarly, when the disease become progressive from moderate to severe, there is subsequent right ventricular dysfunction also occurs, and this gives rise to pulmonary artery hypertension. This is a normal pressure volume loop, and this is the you can see this is the isovolumic contraction phase. This is the filling phase, diastolic filling phase, and here the mitral valve is open and the left ventricle start filling, and you can see hardly any pressure change, whether the volume is left ventricular diastolic volume is 120 ml. So then the isovolumic contraction start and the pressure suddenly increase, and then the aortic valve open, and that is the point where the diastolic BP is recorded. Then the ventricular ejection starts in two phase, early and the late phase, and the end of the ventricular ejection when the aortic valve closes, the systolic BP is recorded. So, but this is the normal pressure volume loop. But however, if you can see in the case of mitral stenosis, and both the left ventricular end diastolic volume and the left ventricular end diastolic pressure, they decrease when you compare with the normal, because this is because the restriction of the blood flow from the LA to LB. So that gives us to decrease in the both volume and the pressure. And there is decrease in the stroke volume also, there is decrease in LV contractility because of chronic LV deconditioning. What is again more important for us, there is some coagulation abnormality apart from the thromboembolic episode and patient is on warfarin or heparin. So there is intrinsic coagulation abnormality as well. So if the patient is on prolonged disease, so one has to go for the looking for the if there is a deranged bleeding status and all, one has to go for the coagulation profile measurement. And if aortic fibrillation, atrial fibrillation started, this pre-existing coagulation abnormality further deteriorate the condition, and it gives rise to hypercoagulable state and stroke. And this is basically evidence if you give anticoagulation and if you go for a pulmonary valvotomy, this hypercoagulability state and stroke, these two things are decreased. So heart rate again, and we all of us know the increase in heart rate gives us to decrease in diastolic filling time and thereby decrease the coronary perfusion pressure. So in order to, in the initial stage, to increase the LV filling, there is increase in the flow rate across the wall. So this gives rise to increase the transvalvular gradient. So tachycardia is always detrimental for the patient. So most of the time, patient does not have any symptom from 10 to 20 years before the in between the acute rheumatic fever until the symptomatic MS. So again the symptoms depend upon the grade of the disease. Dyspnea, palpitation, orthopnea, chest pain, hemoptysis, these are the common symptoms. But what we have to look for basically orthopnea, if it is there, you cannot, most of the time you cannot make the patient supine to induce, you just elevate the table, reverse Trendelenburg and start endorsing of the patient. Otherwise, most of the time patient land up in frank pulmonary edema in the operating room. Next is you have to look for the features of right ventricular failure, because your management will be different. And if there is failure symptom is there, again you have to give some afterload reducing agent. You have to decrease the pulmonary artery pressure by giving the vitamin or milrinol or nitroglycerin. If there is thromboembolic complication, you have to look for features of CVA, or you have to palpate all the limbs basically if there is any the pulse or dislodgement of the thrombus. JBP we have already discussed during case discussion why it is important. BP may be normal, it may be a little bit below normal. Auscultative finding, again I'm not going, that is typical, we have already discussed. What is again more important, you have to look for atrial fibrillation. Rate control is important to improve the diastolic filling time. X-ray chest, again you have to look for any frank pulmonary edema and how much calcification is there, and from that you get a little bit evidence of the degree of mitral stenosis as well. So when, if you can see how the changes can occur, the normal mitral area is 4 to 6 centimeters square, and when it is decreased in the, there is change in the mild stenosis, when it become 1.5 to 2.5 centimeters square, there is not much change during rest. The LA pressure, the PA pressure and the cardiac output is normal. However, in the exercise, all the three pressures are decreased. There's a chance of pulmonary edema. So you have to do some graduated exercise, not much exercise. And in case of the mild, moderate, again moderate disease, when the valve area decreased further, the LA pressure and the PA pressure started increasing, but however the cardiac output is normal during rest, and all these things again increase during the exercise. And again there is chance of pulmonary edema in case of exertion, anemia, thyrotoxicosis, in which there is increase in heart rate or increase in blood flow. All these conditions give rise to frank failure state or pulmonary edema in case if the moderate stenosis is there. If there is again severe stenosis, the valve area further decrease. In the rest also there is massive increase in LA pressure and there is PA pressure, there is sign of pulmonary hypertension, and there is decrease in the cardiac output. So this is a typical echocardiography picture of the case of mitral stenosis. You can see thickened valve. It is a tight severe stenosis. You can see there is lot of smoke because of the turbulence of the flow of the across the mitral valve. So blood is not going. There is mild degree of tricuspid regurgitation also you can see. So these are the conditions when the patient is in atrial fibrillation. So these are the conditions when rate control is very, very important. And intra also you have to look for other thing. You have to ask your cardiologist, or if you are having a echocardiography machine in your OR, you can see. And if there this kind of thing you can see like thrombus in the left atrium or thrombus in the left atrial. And one has to be really careful during the pre-op period to start the anticoagulation, especially warfarin. You have to start in the graded doses, and 5 milligram to start with, go till 10 milligram over the period of 5 days if it is elective surgery, and then you have to titrate and go back to Clexine and or heparin if Clexine is not available. Always look for a PFO, that is a patent foramen oval. You look for the echo report, or if you have echo, you can see the echo. This is important because you have to avoid air in any case to prevent paradoxical air embolism. Classify the severity of the mitral stenosis, valve area, mean gradient, the pulmonary artery systolic pressure, mild, moderate, and severe, and the area is more than 1.5 centimeters square, 1 to 1.5, and less than 1 is the severe. Mean gradient again less than 5 in case of mild stenosis. Some say it is 6. And two guidelines, they say American thought and European thought, two guidelines say in a different way. 5 to 10 and more than 10. And what is more important is again pulmonary artery systolic pressure. If it is more than 50, then it warn a caution. You have to be careful and you have to go for the advanced monitoring. So let's see two cases. And first is a 25-year male acute intestinal obstruction in emergency. This is a follow-up case of mitral stenosis, and patient doesn't have any orthopnea, no other finding, and heart rate is 90 regular, BP is 120/60. Patient is only on penicillin 250 milligram BD. So how to proceed? So obviously you have to go for a blood chemistry, you find it is normal. ECG only P mitral, the rhythm is normal. X-ray chest, there is mild cardiomegaly. Echo, you can see the mitral valve area is 1.8 centimeter square. There is no MR, no TR, and no pulmonary artery evidence of pulmonary artery hypertension. So in this case, what is the anesthesia or anesthetic agent of choice? So obviously, because it's an intestinal obstruction, you have to go for a GA, and you can go for all the monitoring, even if the patient is having the mild stenosis, and all the agents are safe. But however, you have to avoid the tachycardia, you have to avoid the ketamine, and be careful about the fluid and adequate analgesia, avoid hypoxia, hypoventilation to avoid the acidosis, so that the PA pressure will not reflexly increase. Come to the next case. It is again a 35-year-old male and a follow-up case of MS and open cholecystectomy posted for, and heart rate is 80 regular, BP is 167, and patient is on oral penicillin. So how to go about the investigation? So even if because this case is again a little bit surgical risk is little bit more, so you have to go for look for the JBP, all the pedal edema. But one important thing, you have to go for the exercise tolerance testing in this case, because the surgical time is bit more. So at times what happens, patient is having most of the time patient is asymptomatic or having mild symptom, but when it goes during exercise, and it unmarks the poor functional ability and the symptoms are manifest. In that case, you have to be careful. So you go for exercise tolerance testing, heart rate increase, respiratory rate increase to 24, BP is 137/72, but however everything normalized 3 minutes after the rest, and heart rate remain regular. The PA pressure was again 32 millimeter mercury. There is my mitral valve area is 1.8 centimeter square. Again mild stenosis, there is no TR. And so again, anesthesia risk is not much high in this case, because there is not much change. You can go regularly, but anyway you have to go for routine monitoring, and you can try all the drug, avoid ketamine, and need some vigilance, avoid overdose of any sedative, because you have to avoid hypoxia, hypercarbia. Maintain the preload in the normal side or slightly on the increased side. Heart rate again you have to maintain in the normal side or be decreased, otherwise there is decrease in diastolic filling, and intrapulmonary edema can happen. Maintain the contractile function, maintain the SBR, and decrease the PVR. So this is again another case, 35-year-old female for a big surgery, exploratory laparotomy for a benign mass, elective surgery. Patient has dyspnea for 2 weeks, and there is no, but patient has PND off and on for 2 weeks. There is atrial fibrillation, but however rate is controlled. She is on oral penicillin and metoprolol, digoxin, and warfarin. So what is the risk? Because the patient is on warfarin, so that means some thromboembolic episode is there, and plus patient is on arterial fibrillation. And but patient is not, you ask the patient whether patient has to go for mitral valve intervention at the same setting. Patient is not willing to go for the mitral valve intervention at the same setting. So how to go about? And in the pre-op evaluation, you saw there is JVP is raised, but however there is no peripheral edema, and there is no feature of thromboembolism. The other systems, apart from CVS finding, everything is normal. Hemogram, LFT, RFT normal. The INR is 2.6 again. And ECG, there is sign of left atrial enlargement, right ventricular enlargement, and the feature of atrial fibrillation. So echocardiography, there is still is a thrombus, and mitral valve area, there is moderate stenosis. The area is 1.4 centimeter square, and there is a clot in the left atrium. There is mild TR. Systolic PA pressure is 48 millimeter mercury. It's in the borderline to 50 millimeter mercury. However, the other valves are normal. So how to go for? You obviously you have to continue the metoprolol, and digoxin again you have to continue, but at the same time check the potassium level. If the potassium level is fluctuating, either you can go for supplementing the potassium, or you can omit the digoxin the morning dose, because it is a long acting drug. And some patient, they are on beta blocker or calcium channel blocker, and you have to continue the drugs throughout the period. Diuretic, again, if the patient is on, not this case, if some patient is on the diuretic, you have to omit the diuretic in the morning of the surgery, because it decreased down the electrolyte level. And once you have induced the patient is catheterized, you can start on the diuretic and then check the potassium level and other electrolyte level at the same time. Warfarin, again, this case you have to stop at least 3 days prior. In our institute, we are stopping it 5 days prior, and we are shifting to Clexin, that is ultra short acting low molecular weight heparin. And if it is not available, you can go for heparin 5000 units to start with. At the same time, you have to look for the platelet level and INR before the surgery. Maintain the INR between 2 to 3 if the patient is having initial episode of stroke. Other, you have to maintain between 1.5 to 2. And in the pre-medication, again, we have already discussed prevent tachycardia, light sedation, small dose of opioid, and a small dose of benzodiazepine, avoid hypoventilation, and give oxygen supplementation if the patient is required. Intraoperative, because it is a major surgery, you have to go for entire intraoperative monitoring. Echocardiography, if available, yes. If not available, don't worry. Central venous catheter and arterial line catheter is a must. PA catheter, again, some people prefer, some does not prefer, but however, if it is there, it is well and good. It gives rise to status of the cardiac output. And you can see the RV dysfunction, you can measure your fluid and inotrope. Again, the perioperative management, the grid you have to follow. Preload, heart and severe. And try to keep the read less than 60 minutes, because this is critical, and allow sufficient diastolic time for the filling of the ventricle. And don't give full fluid boluses, and fluid should be titrated, and depending upon how much loss is there, because certain fluid bolus give rise to pulmonary edema. And don't decrease the afterload, not because this decrease in afterload, decrease SPR give rise to decrease in coronary perfusion pressure. Again, this can give rise to ischemic feature. Avoid hypoxia, hypercapnia, and acidosis. Again, in this case, because the pulmonary artery pressure is in borderline, you have to avoid nitrous oxide, because it gives rise to increase in pulmonary artery pressure. Suppose a patient is unstable and there is contractility is hampered, and there is feature of right ventricular failure at the same time, you can start some phosphodiesterase inhibitor like milrinone or dobutamine inside the operating room at the same time. And if the patient is having irregular rhythm, which is giving to instability hemodynamic, you can always start some a smaller low dose, and then the maintenance dose 0.25 to 0.5 milligram per kg, followed by 50 to 200 mic per kg. 50 to 200 mic per kg. And amiodarone, again, we are commonly using. Give the bolus, some are using 150 milligram over 10 minutes, and you can go up to 300 milligram over 10 minutes as well, and then maintain 1 milligram per minute for 6 hours, then followed by 0.5 milligram per minute for the rest of the hour. Digoxin, your patient is on, so no need to give. Analgesia, again, fentanyl is a better choice, and give 2 to 5 mics and per kg, and you have to repeat regularly. Look for if there is any tachycardia induced with intermediate or thiopentone, whatever is convenient for you, and maintain a stable heart rate, and avoid ketamine. Muscle relaxant, again, you can go for vicuronium or cisatracurium, or if there is pancuronium also you can give if the rate is controlled. And maintain with oxygen air any volatile agent with narcotic, titrate with the base monitoring. Again, fluid you have to be careful, and maintain the adequate preload. Tidal volume, again, start with 5 to 6 ml per kg, which I also preferred in a low tidal volume. And because ventilating the patient with a large tidal volume, some prefer 10 ml per kg, but this can compromise the hemodynamic, and that decrease the LV preload and increase RV afterload, and subsequently decrease the cardiac output. So better to go for a low tidal volume, 5 to 6 ml per kg. This is adequate enough to maintain the carbon dioxide level as well as the oxygenation. So again, hypotension you have to avoid. If the patient is symptomatic or patient with systolic pulmonary arteries more than 50 and the valve is favorable, then go for a, if it is a elective surgery, go for a balloon mitral valvotomy if it is favorable valve, and or commissurectomy. If the valve is not favorable, then you can convince the patient to go for the mitral valve surgery at the same time setting. And every time keep ready the vasopressor, amiodarone, esmolol and defibrillator in the operating room to overcome any adverse things are coming. Neuroaxial anesthesia is again safe. Many are comfortable with this with the graded of epidural anesthesia because this gives us to gradual offset of peripheral sympathetic nervous system blockade. Neuroaxial anesthesia decrease the afterload, and at times it spinal anesthesia that gives rise to profound hypotension and give rise to poor myocardial perfusion and worsening of the cardiac function. So that's why one should be really careful. So epidural is more preferred. Post-operative again manage the moderate to severe case in a high dependency unit unless surgery is extra minor. So fluid bolus should be avoided, and entire operating room staff should be educated to look for the warning signs, especially there should not be any tachycardia, there should not be any hypovolemia, one should avoid any hypotension, everything should be aggressively treated. So the recovery team members, including the nursing staff, should be trained well regarding the post-op management of this case. Dr. Saneesh, I have some time.
Yeah, no problem. You can go ahead.
Okay. So again, to a brief regarding pregnancy with mitral stenosis, I am not going to the details of the cardiovascular changes in pregnancy because a lot of changes happen apart from the decrease in SVR. There is increase in all the parameters of the cardiovascular system. Mainly there is increase in the volume load and increase in heart rate. So these are the patients who can progress from type mild to moderate or moderate to severe during the case of pregnancy at the same time. And increase in heart rate also, it increase the left atrial pressure and the pulmonary artery pressure at the same time, and increase the likelihood of the pulmonary edema. So if the patient is, again pregnant patient is having atrial fibrillation, that should be addressed immediately because this again gives rise to systemic emboli in most of the pregnant women. So detailed cardiovascular changes again I am not going, but in the start from the second week beyond, second trimester beyond, and continue till 24-week postpartum. You can see both cardiac output, heart rate, and stroke volume, the change almost stable at 12 to 24 weeks. So if the patient is case of mitral stenosis and you are undergoing some surgery, even delivery or any other surgery in the second trimester, one has to be careful and monitor the patient in the subsequent course of time. So for other surgery like mitral balloon valvotomy or any of the minor surgery, or if the patient graded epidural, unless it is obstetrically contraindicated. And so this obviates the tachycardia secondary to labor pain, and it provides good analgesia without significantly altering the hemodynamic. And if unless there is obstetric lesion, avoid the cesarean section. And once the labor pain is started and it alter heart rate, there is lot of uteroplacental circulation imbalance, and there is a less blood flow to the fetus. So you have to monitor the fetus throughout during all stages of labor. If necessary, you can administer supplementary oxygen to increase the pulmonary vascular resistance. And epidural anesthesia, again maintain supplementary epidural anesthesia throughout the immediate postpartum period. You can keep the catheter, epidural catheter in situ, so that you can provide the analgesia in the further course of the time. So the advantage is in epidural because you can give incremental dose. So total dose could be titrated to the desired sensory level. and it has slower onset of anesthesia, so allow the maternal circulation to compensate for the occurrence of the sympathetic blockade. So there is decreased risk of hypotension and decreased risk of uteroplacental low perfusion. So because it gives rise to segmental blockade, it spares the lower extremity, so it forms the venous return. So this is again another advantage. So this in the subsequent course decrease the incidence of the thromboembolism. So however, if the patient is in moderate to severe stenosis, you have to go for invasive hemodynamic monitoring, judicious fluid administration of the colloid crystalloid, and administration of the small bolus dose of phenylephrine to maintain the maternal hemodynamic stability if it is required. General anesthesia, again, if patient is in severe stenosis, but you have to avoid atropine, ketamine, and betadine like drug, and go for a beta adrenergic receptor antagonist like metoprolol for the rate control, especially short acting smaller, but you have to be careful at the same time because severe hypotension can give rise to fetal compromise at the same time, and by decreasing cardiac output. So maintain the fluid at the same time. So modified rapid sequence induction, one can go for using etomidate, opioid, and succinylcholine. This is the ideal agent, especially in case of tight stenosis and patient with pulmonary artery hypertension. Monitoring has to go for invasive hemodynamic monitoring. It is must, especially one has to have a arterial line and a central venous catheter. And post delivery, give oxytocin, not sudden bolus, and 5 minutes to start, and the rest of the thing you can put in 1000 ml crystalloid and give over 40 to 80 minutes period of time. And oxytocin, one has to be careful because it decreases the systemic vascular resistance, increasing the pulmonary vascular resistance, thereby it decreases the cardiac output and increase the pulmonary artery hypertension. That's the why you have to give in a slow infusion. Ergotamine, again, contraindicated because it causes rise to give rise to severe hypertension, tachycardia, PVR. Again, one has to be careful because autotransfusion of the blood from the uterus post-delivery, this gives rise to sudden onset of the pulmonary edema, congestive cardiac failure, and the pulmonary artery hypertension. So one has to be vigilant, keep all the drugs ready for the immediate management of the mother as well as the child. So to summarize, mitral stenosis is a fixed cardiac output state. So avoid tachycardia, increase preload or maintain preload, maintain the contractility, and maintain the SVR, and make the PVR remain at the near normal range. So hemodynamic changes of pregnancy, usually a decompensation of the previously asymptomatic MS. So epidural anesthesia is a safer alternative, and anesthesia management must be based on the individual assessment of the cardiac function and reserve, and an anticipation of the impact of selected anesthetic technique, regional or general, on the cardiac performance. So thank you so much.
Thank you very much, Dr. Minati, for that excellent talk, because you have decided to describe this along with some case scenarios, which will help our junior, younger colleagues to understand the concept better. Thank you very much. Shall I go ahead with the questions?
You can.
Yeah. Now, I think now many of my friends have already raised their hands, and they have put their opinion during our case discussion and the lecture as well. They have put some questions. I would like to have your feedback on these scenarios. So I'll be posting the poll window now. Okay. The first one, a known case of mitral stenosis, moderate stenosis with the left atrial clot, which is recent, on digoxin and warfarin, posted for inguinal hernia repair. INR is 5, no bleeding manifestations. The question is whether you would go for rapid reversal before surgery of coagulation. Rapid reversal of coagulation needed or not is the question. So we would like to listen to you. The poll window is in front of you. You can click either true or false. I think the question is clear.
This audience are answering, no?
Yeah, audience, they are answering. So I'll wait for another 10 seconds only because we have some more questions waiting. Fine. Okay. So this is the response. Dr. Minati, your take on it. 44% said yes, they want rapid reversal, but 56% say they don't want rapid reversal.
Patient is a case of inguinal hernia repair, right? So this is the case because the patient is not bleeding. Again, that is also important. When the patient is not bleeding and patient is undergoing a minor surgery, so rapid reversal is definitely not required. So you can reduce down the dose of the, you can omit the dose. You can omit 1 or 2 dose of the warfarin, or you can reduce down the dose. Suppose the patient is on 5 milligrams, so you can come down to 2.5 milligram, you can wait, or else you can omit the dose. First and second days you omit, again, day 3 you start the routine 5 milligram dose. Or if the patient is having 10 milligram dose, you can go for the lower dose, that is a lowest dose, that is a 5 milligram. And you see the INR. And when the INR is maintaining, then you can continue with the normal routine dose.
So the answer is false, no? Rapid reversal is not absolutely indicated.
Required.
Okay, thank you. So we'll move to the next one. It's a 25-year-old female, known case of mild mitral stenosis, hemoglobin of 9 grams, is posted for fracture reduction, close reduction. Anemia need to be corrected before surgery or not? That's a question. Okay. So you'll have your poll window right now. Initially, I did a poll on the audience profile. So I understand that almost 90% of our audience today are postgraduates. That's why probably they are getting the answers and response and comments very much enthusiastic fashion.
Very good.
Okay. So this is the response. Shall I close the poll window? If anybody wants to put your response now, you can put now. Yeah, I'm closing the poll now. Okay. So yeah, 67% says no, they don't need to correct anemia before the close reduction. Dr. Minati?
That 67% is right. You don't need to correct the anemia because it's a closed surgery. It is hardly take any time. So you need not to correct the anemia at the same time. So, but if it is a major surgery, definitely you have to correct the anemia before.
Okay.
When there is anticipating blood loss.
Okay, fine. So we'll go to some more audience questions, but these questions are already shared along with our Anesthesia Webinar Campus Telegram group. Let's see how this audience responds to those questions. The valve area in case of severe mitral stenosis is option A, 3 to 4 centimeters square, option B, 0.6 to 1 centimeter square, option C, 4 to 5 centimeters square, option D, less than 0.6 centimeters square. So you need to select the single best answer. The poll window is there. And actually we have given the answer along the lecture itself. Yeah, I think if more people can vote, that's fine. So already almost 70% people have voted. It's a good response. You can go ahead. Yeah, fine. So I'm closing the poll now. This is basically a straightforward question right from the textbook. So now 82% says option B is severe valve area in case of severe mitral stenosis, 0.6 to 1 centimeter square. Dr. Minati, a sharp contrast, when we put the question on the Telegram group, when they had enough and more time to check the literature or Google search even, only 63% hit the correct answer. But now during this session, our audience, 82% is hitting the right answer.
Less than 0.6 is critical mitral stenosis.
Yeah, maybe that was one confusion. I think whether even less than 0.6 will qualify as a severe
That
mitral
is
stenosis that is defined as critical stenosis, right?
mitral stenosis.
Yeah. Okay. Fine. So our audience should be clear on these points. So question number 2, the target INR in a patient receiving warfarin for left atrial thrombus in a patient with mitral stenosis is target INR 1 to 2, 2 to 3, 3 to 4, and 4 to 5. Yes, you have the poll window now. Quick response, please. Then only we can take the audience questions afterwards. Yes. Okay, if anybody want more time, yeah, I'll be closing in another 5 seconds because almost straightforward. Again, the trend is more towards clarity this time. Yeah, 91% is hitting the right answer. INR target of 2 to 3, but our Telegram group, the survey, only 76% got the answer right.
At
Dr. Minati?
least it is good. They are working in back.
Yeah.
They are interested to study.
Okay. So again, there should not be any more doubt. So this is the target INR, right? So we'll go to the next.
If patient is having recent stroke or patient is having prosthetic heart valve, then the target INR should be 2.5 to 3.5. In that case, it is a bit higher. Otherwise, it is between 2 to 3.
Okay. Fine. So the question number 3, which among the following anesthetic agents should be avoided in case of severe mitral stenosis with pulmonary hypertension?
This is again we discussed during case discussion
Yes.
also.
Yeah.
And my presentation.
So we'll
also.
see. Thiopentone, sulfurane, nitrous oxide, etomidate. Yeah. I don't think anybody has any confusion now. So let's not waste much time on it. I think everybody is clear. It's a brutal majority. 95% says nitrous oxide should not be used. So this was our previous report, and this is the present poll report. This audience is doing very well.
Excellent.
So we have clarified this point along with the case discussion as well.
Because this increases the pulmonary artery pressure. That's the reason you don't want to give.
Yeah. Okay. Fine. Question number 4. Which among the following is not a pathophysiological feature of mitral stenosis? Pulmonary hypertension, atrial fibrillation, increased left atrial pressure, decrease in right atrial pressure. So anesthesiology postgraduates are definitely expected to know about the clinical features, pathophysiology when we come for a discussion, either in case discussion or viva voce. So these things should be clear. The understanding of the basics will help you to get the anesthetic management right. Okay. Yeah, almost 80%, 79% voted. I am stopping the poll now. Yeah. There is a contrast with the, not much contrast this time. So almost both the groups are zeroing into the right answer. Dr. Minati?
Yes.
Yeah. So pulmonary hypertension, atrial fibrillation, and raised left atrial pressure, these are the pathophysiological factors we come across during mitral stenosis case discussion.
Right atrial pressure is increased basically. It doesn't decrease.
Okay. So we'll go to the next question. Question number 5. Incorrect statement about mitral stenosis is option A, loudness of opening stamp is directly proportional to the severity of the disease. The duration of the diastolic murmur is directly proportional to the length of the murmur. Severe pulmonary hypertension is not uncommon. Cardiovascular, cerebrovascular event can be a manifestation of this disease. Poll window there. I think almost all the postgraduates are ready with the mouse pointer. Yes, another 5 seconds, I'll close the poll if you want to answer. Almost 72% has answered already. Okay, we'll go to the results. 50% believes answer is A and 31% believes answer is B. Dr. Minati? No, there is no consensus in this answer.
There is cerebrovascular accident can be a manifestation of disease because of the thromboembolic phenomenon. Severe pulmonary hypertension is again common. It starts from moderate to severe stenosis cases, so it is common. So duration of the diastolic murmur, again the more the duration, more the length, and it basically directly related. Again, the loudness of the opening snap, it is because of the, as Shinu, while presented, she also described why the opening snap occurs. It is due to last part of, it is dooming of the leaflet, and while it is coming back after systole, so there is fluttering of the bulb. So when the bulb is calcified, it does not flutter. So in that case, the loudness decrease. So the more the severe the disease, the loudness will be decreased. So A is the correct answer.
Okay, fine. Even in the Telegram poll, this confusion prevailed. I think there was a confusion between option A and B. So we'll finalize on option A now. Okay, is it clear?
Yes.
Okay, fine. Next question. Which among the following is not an X-ray chest feature in mitral stenosis? Straightening of left atrial border, double contour of right border of heart, enlarged aortic knuckle, mustache sign of pulmonary vein. Again, this was discussed during the case discussion itself. Yeah, poll window is there. Yes, 5 more seconds. Okay, fine. Dr. Minati, this is
Many
the
hit the
result
right
is,
answer only.
yeah.
Enlarged aortic knuckle, because there is straightening of the left heart border. So enlarged aortic knuckle is only seen in the case of aortic aneurysm or aortic stenosis conditions like that.
Okay. All others we can find in mitral stenosis. Okay. So I think in the Telegram survey also we got only 48%, but the present audience 82% is hitting the right answer. Thank you very much for the energetic response. Question number 7. Which groups of mitral stenosis patients are considered to be at high risk for pulmonary thromboembolism? Option A, atrial fibrillation without additional risk factors. Option B, DVT or pulmonary embolism occurring in past 3 months. Option C, hypercoagulable state without recent thromboembolic episode. Option D, newer model mechanical aortic valve prosthesis and any other tissue valves. We are having the poll window now. Yes, I am closing the poll now. Yeah. Dr. Minati, your take on it. 49% is going with option B, DVT or pulmonary embolism.
That is good. That is the right answer. Atrial fibrillation, if there is any additional risk factor only, suppose there is presence of LA thrombus or LA thrombus, then only there is risk of pulmonary thromboembolism. And hypercoagulable state, again, if there is a recent episode of stroke or DVT or any other thromboembolic episode, they are more prone. And newer model of mechanical aortic valve prosthesis and tissue valve, they're less thrombogenic. That's why now they are preferred. So option B is the right answer.
Okay, so those who have gone for option C should be clear in this point. So option B is the right answer. Right answer is option B. Okay, so even in the Telegram survey, 56% hit the right answer. Okay, we move ahead to the question number 8. The treatment of intraoperative tachycardia or atrial fibrillation in a mitral stenosis patient are all except option A, deepen the plane of anesthesia, option B, esmolol, option C, amiodarone, option D, lidocaine. The poll window is there.
This should they answer correctly.
Yes, I am closing the poll now. Yeah, 78% is going with option D.
So that is the right answer. And lidocaine, if you give in atrial fibrillation, it would convert the thing to ventricular fibrillation. So it is contraindicated rather in case of atrial fibrillation. So if atrial fibrillation against severe hemodynamic instability, you have to get a defibrillator and apply sub, starting with 200 joules external defibrillator.
Let's see how the Telegram group responded. I think in that one, only 33% hit the right answer. Okay, fine. So we have only 2 more questions. Which among the following is not desirable while managing a pregnant MS patient? A, decrease in heart rate, decrease in blood volume, decrease in systemic vascular resistance. Option D, adequate preload.
This also we discussed during presentation.
Yeah, we'll see. Okay, fine. The answering pace has improved, so I need not wait till 30-40 seconds. So 20 seconds, I'll wind up. Yeah, fine. So this is the response. 66% will go with option C.
So majority has gone with the correct answer.
So a decrease in systemic vascular resistance is not desirable. Yeah. We'll see. Yeah, even Telegram survey, 44% were hitting the right answer. So the last audience poll question for you. The anticoagulant of choice in the first trimester of pregnancy is option A, heparin, option B, warfarin, option C, bivalirudin, option D, none.
This should be 100% correct. MBBS question.
Yeah. Okay. I'll wait for another 5 more seconds. Then we'll move ahead with the audience questions. So far, audience had nice participation and enthusiastic involvement in the discussion. Yeah. 82% will go with option A, which is heparin.
That's the right answer because it doesn't crosses the placental barrier.
Okay.
It is safe.
Fine. So even the Telegram group was very close, 84%. I think the poll, when I post in the Telegram, people are not searching for the answers. They will instantaneously select an answer. Okay. Maybe because of that. Okay, fine. So we are coming to the end of the audience poll questions. Now we'll take a few questions in the chat box. There were a good number of questions. I think there are many appearing now during that time. Dr. Shinu?
Yes, sir.
Yeah, okay. Did you read the chat messages by some of your friends during your case presentation? There were good enough suggestions for you, but unfortunately during presentation you won't be able to see the chat suggestions. There were good enthusiastic suggestions regarding the anesthetic management, which physical findings you should look for and all. Okay, so your friends in the audience panel is very enthusiastic and very keen. Dr. Minati, there was a question whether the inguinal hernia case that Dr. Shinu presented, we can manage with the second generation LMA rather than going for an endotracheal intubation.
I think one can manage because it's a short surgery. And personally, I don't have any experience with that, but I think we can manage with LMA.
I think the basic concern during the candidates would be whether the examiner would accept that option. Will it be
Or
universally
not.
acceptable? And
That depends upon the examiner again, most of the time, yes.
okay. Again, there was a query on whether to go for a propofol or etomidate.
Propofol, no, because propofol decreases the systemic vascular resistance, and that decreases the afterload, so that is harmful again for this kind of cases, so one should avoid. And etomidate is more cardiostable, so it's better to go for etomidate rather than propofol, especially if the case is moderate to severe mitral stenosis.
Suppose the examiner says etomidate is not available, then we can go ahead
Then
with
one can go for thiopenton,
okay.
the routine dose, yes.
Okay, fine.
Because that drug is well tested and much proved.
Okay. And I think in the chat there was a query on the angiography indications in mitral stenosis patient. Which patient population? Can you repeat that?
At times the patient is having young patient also nowadays having chest pain and they are having CAD. Suppose the chest pain is unexplained, it is not related to mitral stenosis, and valve is not heavily calcified, that means there is no coronary impingement by the valve, and in that case one has to go for. Secondly, if it is a male more than 40-year, female more than 50-year, then it is a must. Second, the patient is having the history of ischemic heart disease or ischemic heart disease in the family. So these are the condition one has to go for a coronary angiography before proceeding for the surgery, non-cardiac surgery as well.
I know the query is that during a case presentation like this, if the patient happens to be young, what should be the best answer? Like when the examiner says, would you like to have an angiography done?
No, if the patient is 32-year-old, if the patient is having chest pain in this case, and because these are the cases, again the active rheumatic process must be going on to some extent, so that is again another cause of chest pain. So in that case one should not. But if the patient is more than 40-year age, then one has to go for.
Okay.
That is the guideline. 32-year, no. Unless the patient is having a family history or any other symptom of ischemic heart disease, then only one can go for uncontrolled hypertension, renovascular hypertension, then one has to go for. If nothing, simple, this kind of presentation, no angiography.
And in the chat, there was a suggestion to go for tap block for post-op analgesia. Is it acceptable option for an inguinal hernia surgery in a mitral stenosis patient?
What?
Tap block, transversus abdominis plane block.
Tap block one can go for. There is no harm.
And Dr. Shinu has opted for inguinal feed block. Definitely, I think the candidate will be QS'd on graded epidural analgesia for post-op analgesia as well, because it will be longer lasting analgesia.
Longer lasting and more stable. And it will maintain the heart rate and hemodynamic stability. That is more preferable.
Okay. Then when do you have transesophageal echo for mitral stenosis patient? Only for severe cases or with the pulmonary artery hypertension, PA pressure more than 50?
There are several times. Suppose if it is this case patient is stable and patient had undergone echocardiography 1 month before, then it is fine. You don't need any echocardiography in the OR. But yes, if the patient is having moderate to severe mitral stenosis or undergoing a major surgery or any recent episode of hemodynamic instability, or the patient is having atrial fibrillation, at least one has to minor to moderate surgery. One may or may not have the echo in the OR depending upon the availability, but you have to look for a pre-op echo just during or pre-operative visit. But if it is a major surgery, yes, it is better to have a echo if there is a lot of hemodynamic instability you are anticipating. If you are not anticipating, then it is fine. You can go for a transthoracic echo just before the surgery. That is fine. From that you can get a lot of information how the patient is going to behave inside the OR.
Then again on defibrillator, is it a good practice to tell that before I ship the patient, I'll check the anesthesia machine, crash cart and defibrillator and
Yes.
emergency drugs ready before
Yes.
shifting the patient?
Yes. Defibrillator and if possible, if available, temporary pacemaker should be available. Suppose if you are giving shock and patient landed up in bradycardia, sudden bradycardia and hemodynamic instability, patient is not coming up. And in the meanwhile, you had given atropine or something else to increase the heart rate, but patient is severely beta blocked and not coming up. Continuous hemodynamic instability is going on. In that case, you can go for a venous spacing, or if there is a transcutaneous spacing is available, one should go for that.
Mm-hmm. Yeah. And again, during your lecture, you have shown the diagram of pressure volume loop. Will it be nice to know, maybe during Viva also examiner might ask you to, as the candidate, to draw and explain the pathophysiology with the diagram, or it applies only to the fellowship candidates?
Usually they don't ask during the undergraduate stage. Usually. That
Okay,
is
okay.
much more a super specialization thing.
Okay, okay.
The pressure
Maybe
volume.
it's nice to know thing,
But it is
not
if
mandatory.
one can know, that is well and good. But otherwise, it is not mandatory. One should
Okay.
undergraduate, the postgraduate student. It's not that much necessary.
But for fellowship candidates, definitely
Yes,
yes.
it is a must. If you are
Okay.
practicing cardiac, definitely it is a must.
Okay. Then again, during your lecture, you have mentioned regarding the balloon mitral valvuloplasty. If we are giving anesthetic management in the cath lab, should we go in with invasive monitors when the patient is undergoing BMV?
BMB, we usually have a arterial line is a must, and ECG, and we used to have a because the while going through the femoral vessel, the cardiologist only put the another venous sheath inside, so we don't measure the central venous pressure at that same time, but we monitor the arterial pressure, and if necessary, if there is some cross sucker, then we connect with the central line. Otherwise, routinely we don't put any central line that time, but arterial line is a must.
Okay. And I think one of the participants asked, in pregnancy with mitral stenosis, when the patient coming for emergency LSCS where you don't have time for optimization, what would be a desirable anesthetic plan? General anesthesia will be acceptable, or we can offer a subarachnoid block?
Depend upon the stability of the patient and emergency. You suppose you don't have any time, then obviously you have to go for a general anesthesia. But you have little bit time, you have expertise, then go for a graded epidural. It depends upon
Epidural
the
rather than the spinal anesthetic.
no, spinal is absolutely no.
Okay.
Because lot of hemodynamic instability will happen, and it will be difficult to manage, especially the child. It is already an emergency. There is a uteroplacental compromise. There must be some fetal compromise, oxygenation and all. So one should not go for spinal anesthesia. Go for graded epidural if the competency is there, or general, I can say.
This is especially when you don't know how far is the severity of mitral stenosis and you don't know about the PA pressures.
That you can go for a GA in that case. So it will be easier because you have the main thing is handling of the airway. So if any mishap occur in between during your regional anesthesia, so you are in mess. So already you have your airway under control. So if the patient is just postpartum landed in pulmonary edema or anything else, your oxygenation is there, then you can give your diuretic or whatever other drugs plus inotrope. It is very easy to titrate when the patient is on general anesthesia.
I think one of the attendees have posted a scenario like a 35-year-old female, non-case of rheumatic heart disease, history of balloon mitral valvotomy, done 4 years back. Echo shows mitral stenosis with the mitral valve area 1.9 centimeters square, mild MR, EF of 65%, posted for total abdominal hysterectomy. What could be the anesthetic management?
35 year. 35 year.
35 year.
Mitral valvotomy 5 year back.
Yeah.
There is a AST, small AST.
Yes, mentioned only echo mitral stenosis with mitral valve area 1.9 centimeter square
9
and mild.
centimeters square. So it is nearly, you can say, it's a borderline. You cannot say it is totally mild. Also, it is borderline mitral stenosis. Mild MR is acceptable in this case. So it again depends. Patient choice plus the anesthesiologist choice. One can go for graded epidural or general anesthesia. And monitoring, again, you have to go for the total monitoring. This patient mostly behave like a normal patient only, and mild MR is acceptable. It doesn't cause any hemodynamic instability, and it is very common, and we called it is a successful balloon arterial valvotomy if mild MR is there. But only thing one has to prepare, look for the other valve, special the tricuspid valve, and the grade of shunting in across the PFO, whether it is closed or it is not closed. If it is not closed, small PFO is there, AST, I can say, where they rupture the septum for the balloon valvotomy. So one is to avoid AR while giving the intravenous infusion. So that causes paradoxical AR embolism. That one has to be careful.
Okay, fine. I think we have covered most of the questions in the chat. I don't know whether more questions have come up. We have mentioned regarding the anticoagulation already, graded epidural we have mentioned. And
one person has written target INR 2.5 to 3.5 in which group of patient? One person has target INR. Usually we give 2 to 3, but target INR in 2.5 to 3.5 if the patient has embolic episode in the recent past. Number one, stroke or transient ischemic attack, or there is history of deep venous thrombosis in the recent past, or the patient is on the prosthetic valve. So these are the particular group of patient in which you have to keep the INR between 2.5 to 3.5, a little bit higher than the usual.
Okay, fine. I think we have covered most of the questions. Dr. Shinu, you want to clarify something before we wind up the session?
No, sir.
Okay, fine. I think our audience was very much active. We got a good number of questions. I think I'm not touching a few questions because these are very well described in all the literature. The role of neuroaxial anesthesia we have mentioned, infective endocarditis guidelines in mitral stenosis.
That is a guide. The guideline is there. One has to go through that.
Yeah. So yes, and a combination valvular disease, it may not be a part of our post-graduation training, maybe only for the cardiac anesthesia fellowship. I think overall we tried to cover most of the things, and regarding the case presentation, I think the medical part, clinical features, the investigations, the grading, the classification, NMHA grading, all these things are important even for an anesthesia postgraduate in our anesthesia practice itself. Then only we can correlate the rationale behind our choices of drug technique and all. Dr. Minati, with your closing remarks, we can wind up. We had a nice session today, I believe.
Okay, thank you, Dr. Saneesh and Shinu. It's a very good presentation. And audience also very active involvement, and many of you knows most of the answer. Only thing you have to read a little bit, but whatever you are reading, just analyze and put it in practical. That is more important. Suppose if you're in OR, so if you don't see the patient, so patient is the best learning material actually. So you just think of if this is happening, if this is changed, then what is going to happen. So thank you so much, all of you, once again. I have a nice time, I can say that.
Thank you very much, Dr. Minati, for your time and support and involvement in this program. We are definitely grateful to you for your input, and you have taken enough time to prepare the material for this program. And thanks, Dr. Shinu, for your presentation, maybe in a short notice, but you have done well. And most of the audience are in fact known to me. I think from the names I can recognize many people, including Dr. Shinu's classmates and my fellow faculty in our hospital, and many seniors in anesthesia all over India, I should say. Thank you very much for joining. We'll be back with more postgraduate training oriented programs like this in our webinar campus platform. Once again, thanking Dr. Minati and Dr. Shinu and all the participants for your active role in making this program a grand success.